Good afternoon, everyone. You are very welcome to the Model of Care for Integrated Cardiac Rehabilitation webinar. The panel will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you are using an iPad, you will find this feature located at the top of your screen. Without further ado, I will now hand you over to your host for today, Dr. Sarah O'Brien, National Clinical Advisor for Chronic Disease. Thank you.
Good afternoon, everyone. Welcome to the launch of the Model of Care for Integrated Cardiac Rehabilitation in Ireland. My name is Dr. Sarah O'Brien. I'm the National Clinical Advisor for Chronic Disease, and I'm really delighted to be here today with my colleagues to launch this new integrated model of care on behalf of the Integrated Care Programme for the Prevention and Management of Chronic Disease. I suppose this model of care has been many years in development. And it will work to ensure that patients living with cardiovascular disease across the country have access to timely, high-quality cardiac rehabilitation care, no matter where they live. The model of care is being published today, and the link to the digital copy will be put in the chat box, so you can keep an eye on the chat box there for that. So today you're going to hear both the clinician and patient perspectives on the importance of cardiac rehabilitation and the difference this model is already making to cardiovascular care in CHO2 West, where an integrated cardiac rehabilitation service is up and running. So I'm just going to start very briefly with a bit of background before handing over to the National Clinical Lead for the Heart Programme, Professor Ken MacDonald. So just next slide there, please, Linda. So just by way of background, Ireland's population is ageing, and it's estimated that over 1.3 million people living in Ireland are living with at least one of four major chronic diseases, namely cardiovascular disease, COPD, asthma, and diabetes. And due to advances in medicine, we're now living longer, but living longer with higher levels of chronic disease. And so our health service needs to adapt to meet the evolving needs of our population. And it was against this backdrop that the HSE's national clinical programs for heart, respiratory and diabetes, which are made up of clinical consultant leads, nurse leads, HSCP leads and clinical advisory groups, and who provide clinical leadership to the HSE, came together to form the Integrated Care Programme for the Prevention and Management of Chronic Disease. And the objectives of the ICPCD are to maximise preventative health services, enable people to optimise self-management of their conditions, and to support the provision of GP-led primary care. Next slide, please. So the rollout of the integrated model of care for the prevention and management of chronic disease as part of the Enhanced Community Care Programme is working to address these challenges. It provides 5 levels of care spanning community and hospital. Level 0 at the base there in the blue is about empowering patients to self-manage their chronic conditions by arming them with the tools and knowledge to do so. This is at the base of the pyramid, and it takes varying forms, but every patient should be empowered by their healthcare professionals in this way. Level 1 in purple there is general practice, and in particular the structured chronic disease management program in general practice. Levels 2 and levels 3, green and red, are new levels of care in the community based in the ambulatory care hub and hospital. 30 chronic disease community specialist teams will provide timely and equitable access to diagnostics and specialist multidisciplinary team advice in the community to support the GP in providing holistic, person-centred care for patients living with more complex chronic disease and multimorbidity as close to home as possible. And at the top of the pyramid is acute hospital care, which can't always be avoided, but the focus will be on early and supported discharge where possible. Full implementation of the model of care will provide end-to-end care for individuals living with chronic disease and multimorbidity in the community. And cardiac rehabilitation will be offered in both the community and hospital ambulatory care settings. Next slide, please. So I'll now hand over to Professor Ken MacDonald, who is the clinical lead for the National Heart Programme, who will give a brief overview of the need for cardiac rehabilitation and this model of care. Thanks, Ken.
Thank you, Sarah. I hope everyone can hear me clearly. It's a great day, as Sarah's pointing out, because this has been a lot of work has gone into this, and a lot of people, many of whom are in the audience here today, and to everyone who's contributed, a big thank you, because this is a critical document to put in play a uniform process for cardiac rehabilitation across the country. So I think well done to everyone who's been involved in this. Sarah's already outlined the absolute need for cardiac rehabilitation, and increasingly there is this need because of the demographic changes we're seeing in our society with an aging population, increasing prevalence of risk factor controls, yet in that context where cardiac rehabilitation has played a critical role in risk factor care, risk factor management, we have really had limited capacity to cover our patient population in its entirety by the presently applied or up to presently applied resources for cardiac rehabilitation. You can see the figures there on the right-hand side of the slide. And in particular, there have been some populations, such in particular the heart failure population, who have even been further or more notably disenfranchised by the lack of resource for cardiac rehabilitation, and something which we hopefully will be now able to address. And this lack of uniformity for cardiac rehabilitation was highlighted in the iAspire data, which is really important data from this country, which shows the lack of uniformity and risk factor control across the country, again reflecting the resource difficulties we have had up until the development of the integrated care program and this model of care in attacking this issue. Next slide, please, Linda. The history of cardiac rehabilitation in Ireland is a very auspicious one. It's 5 years away from its 50th anniversary, and it's really contributed to the healthcare, the cardiovascular healthcare of the population over that period significantly, despite the fact, as I've mentioned in the previous slide, that resources have never really reflected need. But cardiac rehabilitation has always been central in whatever document we've had at a particular time over that last 45 years, whether it's building healthier hearts, or as you can see, those documents listed as we went through the last few decades. But I think there's really been a sea change with the sláinte care approach, and really that's challenging us all as healthcare providers to everything that Sarah outlined in her introduction to the integrated care model for chronic disease, to be able to provide uniform, high-level care across the country. And as I say, with the enhanced community care programs, with the hubs, and with the increased resource, and obviously we need to build further on this resource for cardiac rehabilitation, we anticipate a significant uplift in the quality of care we can give patients. Next slide, Linda. And the aim, really, everyone can read it there, but it's important that that aim is read by everyone involved in cardiovascular care and specifically in cardiac rehabilitation, because I think it underlines very succinctly what we're trying to do with the model of care for cardiac rehabilitation. And as I said, I'm not going to read it because everyone can read it, but I think important to just focus even on that those last four words, regardless of setting. I think it's important that we're now making something that's user-friendly. And the objectives, as laid out on the left-hand side, was to be guided entirely by the evidence. And again, I must compliment everyone that's been involved in this. And this is not patting my own back because I was peripheral to the effort. But everyone who went into this in great detail to ensure that a model of care reflects best practice and lays out in clear practical detail what the components of an optimal cardiac rehab program should be, and also underlines the need for us to be able to audit what this expanded resource is bringing to patient care to make sure that we are achieving the aim. And again, on the right-hand side of the process, underlining the importance of the multidisciplinary nature of this intervention, and also now the patient-centered nature of this intervention and the need for us to make it accessible so that our patients can avail of this expanded resource. And I'll leave it at that. And again, just to finish off by saying again, so it's wonderful that we've come to this process now. The challenge will be to implement and for our patients to see the benefit of this. Thank you, Sarah.
Thanks, Ken. Now I'm going to hand you over to Professor Bill McAvoy, who's consultant cardiologist in Galway University Hospital and chair of the prevention subgroup responsible for the development of the model of care. Bill is going to give you a brief overview of the model. Thanks, Bill.
Thank you, Sarah. Welcome, everybody. Good afternoon. For those that don't know me, I'm a consultant cardiologist and also academic professor of cardiology in Galway. My focus is in preventive cardiology. I also direct the Irish National Institute for Prevention and Cardiovascular Health. And it's really a pleasure for me today to make some remarks on this exciting new evidence-based patient-centered model of care for cardiac rehab. As others have said, today marks the culmination of years of work. We started this process of developing the model of care in 2019, but arguably some of this work was done even prior to that. Obviously, progress has moved forward more recently in earnest since the rollout of the integrated care program in chronic disease. I've been fortunate to be involved in prior international clinical practice guidelines, and I can say with confidence that this model of care was developed following a very rigorous methodology that we can stand behind. And as you can see, a number of steps were taken along the way to get us to the point we are today. And those steps include the health needs assessment that we undertook prior to the development of the model of care, the establishment of a prevention subgroup as part of the clinical advisory group to the National Heart Programme, literature review, stakeholder consultation, including a wide range of stakeholders. And I will say that part of that involved engagement and review of literature around patient preferences, both as a result of our work here in CRE and NIPC, but also international work in the area of patient preference around cardiac rehabilitation. We also sought the input of content experts, and then once the document was ready, moved forward with formal approval by the clinical advisory group to the National Heart Programme. So basically the cardiology consulting group in Ireland. I've reviewed this document, approved it, and then forwarded for approval to the National Clinical Advisor and Group Lead for Chronic Disease, and subsequent sign-off then by the Chief Clinical Officer, Clinical Forum of the HSC. So next slide. Let me provide a very quick definition of cardiac rehabilitation and an overview. Cardiac rehabilitation is a complex intervention that consists of a coordinated sum of activities required to influence favorably the underlying cause of cardiovascular disease, as well as to provide the best possible physical, mental, and social conditions so that the patient may, by their own efforts, preserve or resume optimal functioning in their community, and through improved health behavior, slow or reverse progression of disease. This is a very broad definition, but cardiac rehabilitation is a broad multi-component intervention. We know that cardiac rehabilitation consists of 4 phases. There's phase 1 in the inpatient setting, where the patient is initially engaged around the idea of cardiac rehab and the referral during their acute hospitalization. Phase 2 is contact with the patient during the immediate post-discharge period. Phase 3 is where a lot of the work of cardiac rehabilitation is conducted, and that's a structured, comprehensive prevention and rehabilitation program, including a number of core components that we'll go through. And phase 4 is the concept of maintenance to try and prevent long-term recurrence of disease. Next slide. So cardiac rehabilitation is cost-effective. It reduces mortality, reduces hospitalizations and morbidity, and increases quality of life. There's no doubt about that. It has a very long and strong evidence base. And cardiac rehabilitation is recommended in international clinical practice guidelines, again, which I've been part of, as a class 1A recommendation. It gets the highest level of recommendation with the highest level of evidence behind it, specifically in patients hospitalized after an acute coronary heart event, coronary vascularization procedures, or heart failure, specifically systolic heart failure. And these recommendations come from a number of international societies, including European Society of Cardiology, American Heart Association, American College of Cardiology, and so on. I think the most important thing to say about cardiac rehabilitation is, though, it only works in patients who get it. And we also know that a really critical aspect to success in cardiac rehabilitation is the time that it takes for a patient to be referred and to receive a place in the cardiac rehabilitation program and undergo the initial assessment. So we need more places, and we need timely access to more places in Ireland. We know that from the health needs assessment. And this model of care leverages the opportunity that exists around the integrated care program to provide cardiac rehabilitation, not just in the hospital, where we've been doing an outstanding job historically, but also to expand that with more options, more resources, and basically more cardiac rehabilitation slots for patients into a community setting. Next slide. So this model of care covers a number of aspects of cardiology. I'll say from the outset that we cover phase 1, through phase 3. This model of care does not cover phase 4 of cardiac rehabilitation. We have a number of steps that we've outlined in the model of care. Step 1, as you can see, is phase 1 of cardiac rehabilitation, and that's the early inpatient contact with the cardiac rehabilitation service and referral to phase 2 and 3 cardiac rehabilitation. Phase 2 is managing the referral, which is important. And we wanted to really make sure that this model of care facilitates shared decision-making around the site of cardiac rehabilitation with involvement from the clinical care team who help to triage the patient to a hospital or hub setting, but also importantly with patient input around their preferences to ensure that we can maximize the number of patients that will attend cardiac rehabilitation, again, a life-saving service. So we really focused on patient choice and engagement, which we know from international research is an important aspect in terms of recruitment and retention into cardiac rehabilitation. Step 3 is phase 2 cardiac rehabilitation, and that's the structured phone call or home visit. Phase 3 is the next step, which is really important in cardiac rehabilitation, the initial assessment and development of a patient-centered care plan. As part of that, we deliver in step 5 a standardized set of cardiac rehabilitation components, which I'll outline in the next slide. All of these are evidence-based components and really key to ensuring that the cardiac rehab that we deliver reflects the cardiac rehab that was delivered in the research, demonstrating its efficacy, its benefit for patients. Next step is the end of program assessment and discharge with community services for support and long-term behavior change. An important aspect of this is that we in Ireland have not had a very structured, consistent approach to capturing the effect of the cardiac rehabilitation intervention in terms of the initial assessment and end of program data with respect to change during cardiac rehabilitation. And really this model of care puts as a priority the need for data collection around cardiac rehabilitation in Ireland so that we can understand how we're doing, how we need to improve, and how we can maximize the benefit for patients. And then the final step is, as I said, evaluation and an audit, basically, which is a cyclical process. Next slide. So these are the core components: health, behavior change, education, physical activity, exercise prescription, including treadmill, smoking cessation, dietary interventions, psychosocial health, and really important medical risk factor management. And we wanted to focus on all aspects of these core components in this model of care. Next slide. So clinical governance is important. The model of care covers both the hospital and the community hub settings. The hub settings are HSC HSC centres where healthcare is provided, covered by the HSC indemnity scheme. And we've been very conscious to ensure that the sufficient equipment is there, and really took this model of care with the view that we wanted the hospital and community hubs to be equal in terms of resources and so on, and safety with respect to patients undergoing cardiac rehabilitation, which is a very safe intervention to begin with. Each hub is, as you know, comprised of 3 community healthcare networks and aligned hospital. We really want the hospital-based and ambulatory care, hub-based cardiac rehabilitation staff to work together to provide a singular integrated cardiac rehab service for the region. There's no point in being siloed. We want to have everybody working together to improve the delivery of cardiac rehabilitation for our patients. One consultant cardiologist will provide clinical governance for the hospital and community-based components of cardiac rehabilitation in each hub. I will say that integrated care cardiologists have been funded for each hospital and aligned hub, and the expectation is that they will provide clinical governance to the CR services across the hub and hospital after discussion with the rest of their colleagues. Each cardiac rehabilitation service will importantly develop and implement a pathway for accepting and managing referrals for all patients referred to the cardiac rehabilitation service in the local hospital or hub setting. Next slide. Patient centeredness is key, and we'll hear from a patient later in the webinar. And we came to this model of care having reviewed the literature in this area and understood the needs that patients have expressed with respect to accessing cardiac rehabilitation. And really, each component of this cardiac rehabilitation model of care was designed with the patient at the center. Both the referral, the initial assessment, the setting of personalized goals, a tailored care plan, multiple modes of participation to improve access and ensure that patients are exposed to as much of this life-saving intervention as possible, family involvement as if desired, and self-management for long-term behavior change. And we hope that this updated evidence-based model of care with a patient-centered focus will help to maximize the effectiveness of cardiac rehabilitation in Ireland. Next slide. As I've mentioned before, a core component of the model of care is the need to understand how we're doing, collect data with that in mind, and to try to ensure that where we are not doing well, we improve and feed into that quality and audit loop. So we expect the continuous monitoring and improvement of cardiac rehabilitation, delivering a safe, high quality, evidence-informed and equitable service. And the model of care was designed to support that intention. We obviously want to support national and regional surface planning to meet the population needs, identify accessibility challenges and hard to reach groups. Part of the model of care was developed with that in mind to increase options for patients. We want to optimize the patient experience and outcomes. And really importantly, data should be returned to the local governance group and the enhanced community care program so that we can study how we're doing and improve where we need to do better. As part of that, we are recommending in the model of care development of a national audit for cardiac rehabilitation, which is something that we haven't had consistently so far. Next slide. A number of key recommendations come and next steps will be important in implementation of this document. There's important work that needs to be done establishing appropriate governance structures across hospital and community CR services, the need to develop operational plans for multidisciplinary integrated working, identify and advocate for a required level of resources to support delivery of cardiac rehabilitation across hospital and community needs. And we recognize that the resources that we have, while a huge improvement on historical resources, and with the integrated care program now, a huge increase in the number of cardiac rehab offerings available to patients and improved patient choice, we still have some work to do to optimize delivery of cardiac rehabilitation and to optimize the resources available to cardiac rehabilitation in Ireland, including dietetics and psychology support, which we've advocated very strongly for in this model of care as we go forward. And then the need to identify staff training and education needs so that our cardiac rehab workforce is up to date, engaged, and committed to delivering on this model of care. Next slide. Oh, I'm finished. And thank you very much for taking the time to join us today.
Thanks a million, Bill. So just a reminder to all attendees, please add your questions to the Q&A box there. I see the questions are starting to come in. We'll try to answer some of the questions in real time if possible. But for any questions that aren't answered today, we will be circulating a frequently asked questions document with your questions included and answers included to support sites in the implementation of this model of care. So I'll now hand over to Mr. David Kelly. David is the chair of the Heart and Stroke Voice Ireland, as well as special projects lead in the Global Heart Hub. And David is going to speak to the patient perspective. Thanks, David.
Thanks, Dr. O'Brien. Hi, everybody. I'm delighted to join the call today as a CVD patient myself and also as chair of Heart and Stroke Voice Ireland, and to bring the patient community perspective to the launch of the new cardiac rehabilitation model of care. HSVI was formed, I should say, earlier this year as an alliance of heart patients, stroke survivors and their carers. And one of the key aims of the group is to highlight unmet patient needs and to advocate for change and action where it's needed. And indeed, cardiac rehab was actually an area that was on our radar. So we were delighted to learn of the great work being done to bring this model of care to fruition. As a group, we know that successfully implemented cardiac rehabilitation is proven to reduce recurrent cardiac events, reduce anxiety and depression post-event, and overall to enhance one's recovery after a cardiac event. For us, today's launch is a milestone that signifies a renewed commitment to ensuring that every individual patient, no matter where they live in Ireland, has access to timely, high-quality cardiac rehabilitation care. Previously, we know that many patients have struggled to complete their full rehab programme as a result of a mix of geographical barriers, time constraints, or the fact that the programme on offer did not fully recognise their own unique needs. Rehab programmes have largely only been available in hospital settings, and each programme across the country has operated with differing levels of staffing and staff training, resources, availability over days and weekends, and varying levels of waiting times. And that's if a cardiac rehab programme was even available or offered in their area at all. We welcome that central to this new model is the recognition that every patient is unique and that their journey towards recovery should be treated as such. On that basis, we are delighted to see that one of the key aspects of this model is the emphasis on setting individualised goals. And indeed, Dr. Bill just spoke to that a few moments ago. By tailoring rehabilitation programs to the specific needs and aspirations of each patient, as envisaged in this model, we will see the health service continue its move away from a one-size-fits-all mentality, and that is to be very much welcomed. We welcome also the fact that in alignment with the Sláinte Care vision, this model recommends the integration of cardiac rehab services across hospital and community hub settings. This integration is crucial for providing seamless care that transitions smoothly from acute medical episodes to ongoing rehabilitation within the community. Recognising the importance of the community in the recovery journey, we want to ensure that patients are surrounded and have access to their loved ones. This not only contributes to their physical recovery, but also addresses their emotional and psychological aspects of healing also. Of course, and again, Dr. Bill alluded to it a few moments ago in the key recommendations, the elephant in the room here, as it often is adequate resourcing of our healthcare system to implement this new model of care as it's envisaged. This factor is crucial for its implementation to be successful, and certainly from HSVI's point of view, we'll be calling on the relevant stakeholders to ensure that whatever funding is needed is made available to implement this now best-in-class model of care. And it's great to see so many people on the call today, and thank you all for joining.
Thanks, David. Thanks for that. So now, Dr. Susan Connolly, who is an integrated care cardiologist in Galway University Hospital and the Galway City Hub in CHO2 West, will speak. And Susan's going to speak to the lived experience of establishing and running the integrated care service in CHO2 West. Thanks, Susan.
Thank you, Sarah, and thank you to everybody for having me on this panel today. So yes, I have the joy of the lived experience, and it's not for the faint-hearted. But what we're doing here today, I think, is so incredibly important, and I think this marks a very exciting time going forward in Ireland in terms of building cardiac rehabilitation services for all. I work in CHO2 West. I'm a cardiologist in Galway University Hospital and the Integrated Care Hub in Galway City. We have two other hubs in the area, the Mayo Hub, and we also have a hub in East Galway. And we have 4 university hospitals in this area: Mayo, Galway, Roscommon and Portiuncula. And that means we have potentially 7 cardiac rehabilitation programs. So what we wanted to do was be strategic about how we implemented this to make sure we were addressing the needs of patients. Next slide, please. So the first thing I did, and I'm very grateful to the hospital cardiac rehabilitation teams in the West, in Mayo, Roscommon, East Galway and Galway, for opening up their doors to me and giving me access to the types of program they're running, the types of staffing they have, and so on. And what we found, as David alluded to and as Bill alluded to, there are gaps. We have different levels of nurses at different grades. We have varying MDT representation. In particular, we have no dietitians in the West for cardiac rehabilitation. We have limited physiotherapy support and limited admin support. The programme and assessments do vary by site. The proportions of patients who are eligible for cardiac rehabilitation vary per site, and that's a resourcing issue. Wait times are too long, again, a resource issue, and there is insufficient consultant support. And this results in patient inequity. But now we can improve things. Next slide, please. So what we did was a lot of work around mapping where our patients come from. And we took cardiac rehabilitation referral data for 2022 from the 4 existing hospital-based programs, and we mapped them by postcode, by air code, by primary care team, and by network. And on the right of the screen, you can see the 4 existing hospital-based programs. And then we were able, if you just advance the slide. Yeah. So now we have implemented our 3 new community-based programs. In Mayo, we have just started a program in Ballina. In Galway City, we have now one in the west of the city. And in East Galway, we now have a program in Athenry. There are still gaps, and we will hopefully be implementing a further program in Roscommon and then out in the west near Clifton. But you can see from the additional green hubs that have been added, we are starting to offer patients more choice and care closer to home. Next slide, please. We were conscious, though, having 7 programs could potentially lead to chaos. And as I said, we wanted to be strategic. And what we are implementing in the West is a regional integrated cardiac rehabilitation program, our service. And for that, we need the right governance. We're very lucky to have a strong steering group in the West, chaired by the CEO of CELTA and the head of primary care. We have a cardiac implementation group for integrated care. And now we have a joint working group for the implementation of a regional service. And this will involve mainly the key nurses who are delivering cardiac rehabilitation throughout the region. But we are also going to implement a CNM3, who will be the regional lead nurse for cardiac rehabilitation across the 7 programs. Although there are consultants in each hubs for cardiology, and they will have the governance of patients in the hub and hospital, I am taking on the consultant strategic lead role for the regions to direct on how we're going to do this. It is key to remove variation, and now with the model of care, we can move towards a standardized initial assessment, end of program assessment, and delivery of the core components. There will, of course, be local variations. Our hospital programs have gym equipment and telemetry, and that will, of course, continue. The community-based programs won't. We have now started a regional referral log. One of my fears was there's a lot of patients across the region moving between various hospitals. We want to make sure we're capturing our entire eligible population and that we know where they're accessing their cardiac rehabilitation. And we also want to make sure patients have choice. So when we meet them in hospital, we discuss the options with them and they get to pick where they want to have their cardiac rehabilitation. And it's not just about choice of venue, it will be about choice of mode of delivery. We haven't started yet our virtual program, but we will be delivering a virtual option and a home-based option and a hybrid approach. One of my concerns was about the division between hospital and community, and I think it's really important we bridge that gap, and we're doing that in the West. What we have now is an inpatient rota coordinated by the acute 50/50 CVD nurse, and that's for pickup of patients in hospital, the so-called phase 1. And on that rota, we have the hub CVD nurses, we have hub cardiac rehabilitation staff, and also the hospital cardiac rehabilitation nurses. And they take it in turns to come in, meet the patients, and log them on the referral log. Another important way that we have implemented joint working is I lead a consultant MDT. My counterparts in Mayo and East Galway do similar, and both hospital and community cardiac rehabilitation staff join the MDT, so we're all working together. What's really important, as Professor McAvoy said, though, is we measure what we are doing. Are we being effective? And I think that's where having the standardized initial and end of program assessment with clear definition of what clinical outcomes we'll be measuring, but not just clinical outcomes, also patient reported outcomes, because what matters, what is important to the patients, and are they feeling better? Has their quality of life improved? Have their psychosocial factors such as anxiety and depression reduced? This is not a one-year project. I think this is a 3-year plan. It's going to be slow, but we are making steady progress. And I think we're going to transform the delivery of preventive cardiology care, cardiac rehabilitation in the West. And now we're just going to show a short video to show you some of the work we've been doing.
I'm Dr. Susan Connolly, Consultant Cardiologist, Integrated Care in Galway City Hub. I'm here today to talk about the importance of cardiac rehabilitation. So I think the model of care is an incredibly important development in cardiac rehabilitation in Ireland. It essentially gives us a roadmap of standardised model of care we can give to our patients, whether it's in a hospital-based programme or in a community-based programme. It describes the core components that make up good quality or high quality cardiac rehabilitation. So it'll take away the lack of standardisation that currently exists. So now, no matter where the patient accesses a programme in Ireland, they will get the same standard of care. Cardiac rehabilitation is an essential treatment for a patient who's had a cardiovascular event, like a heart attack, or who've had heart surgery. It's life-saving. It reduces their risk of dying in the longer term. The programme supports patients in their recovery. It supports them in leading a healthy lifestyle, managing their risk factors such as their blood pressure, their cholesterol, making sure they're on the right medication for them that would protect their heart, and addressing their psychosocial health, reducing anxiety and depression, improving their quality of life. So ideally, cardiac rehabilitation should be started within 2 weeks of discharge.
We complete phase 1 assessments in the hospital and then provide a service for onward referral for patients, allowing them to choose a venue of their choice for their cardiac rehab programme. And then on programme we offer an initial assessment where we look at their medical, lifestyle and psychosocial risk factors and develop a plan, a holistic plan with them.
Patients say about how much they've gained confidence having come to the cardiac rehab programme. They find it really beneficial. They get a lot of peer support from the programme and they just feel like they're getting back to their self, which is really nice to see.
Psychology can help people to process the trauma, to adjust to their life post-heart attack or cardiac event, and to get back to their regular lives.
I had a heart attack in October 2022. I had a stent put in and spent a few days in hospital. When I came back out of hospital, that's when things kind of hit me, mentally and physically. So when I heard about rehab, and I was a bit apprehensive about it, but it's given me hope. It's given me a feeling I can get back to what I was. And I would encourage anyone who has a heart attack or a stent, go for it. You can come back to yourself, you can even get better, and I feel the benefits, and I'm looking forward to years more.
Now, hello, can you hear me there? My video isn't working for some reason, but just to say thanks, Susan, for that piece, and for the video there. I think Anne's speaking around you know, talking to other patients who've had a heart attack or a stent and saying, go for it. That's what we really want to enable. We really want to enable patients to go for it, to participate and to feel the benefits of cardiac rehabilitation. And that's what this model of care is really all about. So now we're going to move on to our questions and answers section and our panel discussion. So we might just get all our speakers to put on their cameras there. Even if I can't put my own on for some reason, I'm not sure why it won't work. But anyway, you can all hear me okay?
Yeah.
Yeah, okay.
Yeah,
so
perfectly.
A few questions have come in, and I thought I might just start with this first one, Susan, because you touched on it in your slides around this model of care being an integrated cardiac rehabilitation model. And you talked about the integration across the hospital and community, but what does that actually mean for the patient?
So what we don't want is a siloed approach and patients falling between two stools. I think it's really important that all the patients within our area, that we know where they're going and that they're going to a venue of their choice. But it's not just about that pathway. It's about the hospital program and the community program not being separate programs. We're all delivering the same thing, maybe in slightly different ways, but we all want to achieve improvements in medical risk factor management, lifestyle change, and so on. And I think the joint MDTs are absolutely key. So when I do this on a weekly basis, I have my hospital nurse there and my community nurse there. And some patients even move between the two. And I think that's true integrated working.
Thanks, Susan. And there's a number of questions in just around the resourcing of the model of care. And I might just pose this one to you, Ken, around the importance of the multidisciplinary team and where dietetics comes into it and whether that's been resourced.
Thanks, Sarah. And I think Bill and Susan have both touched on this already. There's obviously a lot of extra resource now going into integrated care for chronic disease and specifically into cardiac rehabilitation, but the job is not done. Both my colleagues have pointed out the lack of resource that we have at present for specifically dietetics and psychology, but we'd have to look at the totality of the multidisciplinary approach and ensure it's all uniformly resourced, because it is absolutely critical. And we know that from looking at international best practice, which again, we're very lucky to people of the caliber of Bill and Susan who have experience of this internationally to know what we should be doing here, leading this effort here in Ireland. And just to reassure people who might think that this is the end of the development of cardiac rehab or any other aspect of chronic disease and cardiovascular medicine, it is, I would regard as the start, and we've still got work to do. And again, going back to the question, Sarah, that work will have to focus on getting more dietetic support, more psychology support for the cardiac rehab program.
Thanks, Ken. Very important point. You know, the emphasis is around this being multi-component and every component being so important, and dietetics is one of those pieces, and that's clearly called out in the model of care. I might just move to you, David, just around your experience as a CVD patient. In terms of recruiting and retaining patients, how important is that person-centered approach, do you think?
Yeah, there's no question. It's critical. Actually, I had my second open heart surgery in April of 2021, and I didn't partake in a cardiac rehabilitation program because it wasn't offered to me after I left. So I suppose I'm coming at it from that perspective. And I mean, there's no doubt that rehabilitation goals, when they're jointly agreed at the outset and with the patient, like that's a critical component to success of the overall rehab program itself. And I think that's person and patient-centered approach is the cornerstone of a good model of care, and it seems to be well embedded in the model that's on display today. And like everybody has different needs when they come out. Like I'm reminded at our HSVI launch in June in Dublin, one of my fellow affiliates in that organization, Heidi, she spoke. She's a stroke survivor. She's in her mid-20s. She's now expecting her first child. And then a neighbour of mine just down the road here had a stroke about 2 or 3 months ago. And their needs when they come back home are, they're wildly different. They're at completely different opposite ends of the scale based on age, gender, lifestyle choice, etc. So this kind of, it is very heartening to see. And again, Dr. McAvoy, he had a slide up there on the patient-centeredness approach. I think if we tick those boxes as we go through this process and keep the patient at the center of the actual process itself, I think that can only lead to good outcomes. And the move into the community in particular, as actually I'm based not far from Athenry myself, so I was very interested in looking at the map there, Dr. Susan. So I'm in Monivea. So that's fantastic. I live in a rural area, and you can see already that there's progress out into these areas, which makes that standard of care available to the patient much closer to home. And again, that's a fantastic development. I suppose I would resources have been mentioned by me and by some of the medical professionals on the call as well. So I suppose, and Dr. Ken or Professor Ken mentioned it as well, that this is the start of the process, but it's one we certainly welcome and one we'll certainly support all the way that we can. And we'd certainly stand behind any call that's needed for additional resources to make sure it's seen right throughout the country.
Thanks, David. That's great, and you're right in terms of the resources. It's always a challenge, and this model kind of sets the standards that we need to work towards achieving. So it's a work in progress. Just I see a number of questions coming in there around telemetry and whether there'll be access to telemetry in the hubs. Bill, I might send that question to you.
Yeah, we have provided funding for telemetry in the hubs, and we leave that at the discretion of the local team. There's obviously a long-standing debate about the need for telemetry with cardiac rehabilitation, which really is a very safe intervention. And obviously since COVID, we've learned a lot about how to deliver cardiac rehabilitation using more novel, innovative approaches, many which don't include traditional telemetry. That being said, we wanted to provide choice to the local teams, and we had feedback that telemetry was something that was desirable to some of the local teams, and so those resources were put in place, again informed by the local clinical team.
Thanks, Bill. Thanks for that. David, I have an interesting question in here posed to you. And the question is whether you think that cardiac rehab teams should consider the expert patient involvement in delivery. So patients that have gone through cardiac rehab themselves being involved in supporting the delivery. This has been seen in other centres in Europe and seems to be a powerful support to new patients joining or new people joining a programme. Just interested in your thoughts on that.
Well, I suppose you won't be surprised by my answer when I say absolutely. That's part of forming HSVI earlier this year is the CBD community has been largely disjointed in Ireland. So we're coming together, I suppose, as a group of patients with lived experience and also carers to try and just kind of unite that voice. And there's no question, there's a lot of good people within the group who have already gone on. And, even myself, I was at the Irish Cardiac Nurses Association AGM in Killashee earlier this week, just speaking on the patient voice as well and the patient at the centre of care. So, absolutely, I would think that any time a model of care or anything like this is developed, that the patient should be brought in at the start of the process. And we are heartened to see, the HSE patient partnership was actually on in the CCD in Dublin on the same day that I was in Killashee, and if I wasn't in one, I'd have been at the other. So it is heartening to see that move towards involving the patient right from the outset of these processes, is starting to happen in Ireland as it has in other countries. With my work with Global Heart Hub, I suppose we see an international perspective as well, and there's no question that some countries are more advanced than us in this space, but there's no question either that there is momentum behind it. And I think the more that the patient voice is heard in the likes of this environment, and as I say, right throughout the process, I think they can only bring benefit.
That's great, David. Thank you. Thanks. A couple of questions coming in just around the measurement piece and evaluation. So the model of care talks about the various components and delivering standardized care. And I suppose, Bill, how will we know we're achieving that goal?
Yeah, I think I'm conscious on the call that, you know, we come from a place in Ireland where cardiac rehab has been under-resourced. We don't have the access that we need for the patient demand, and there's huge heterogeneity around the country in how we deliver cardiac rehabilitation, and that comes from long-standing resource difficulties. And this model of care is a step in the right direction. And really, we hope that by implementing this model of care, we will make a major improvement in delivery of cardiac rehabilitation services in Ireland. But we also recognize that this, like Ken said, isn't the end of the journey. It's really the start in many ways. And we have to back up this model of care with implementation, but also with evaluation. And I think that's really important. That's something that the model of care and I hope people will be very supportive of this model of care, because it is at its core also a mechanism to evaluate how we're doing so that we can improve services going forward. There's no point in complaining about the lack of resources and so on if we don't have the objective data to help the stakeholders improve the delivery of services by providing the resources that are identified to be needed. So this model of care tries to focus on that, as well as improving the choice for patients and so on and so forth. In the first instance, cardiac rehab services will be monitored and evaluated as part of the integrated care program, and that's part of the enhanced community care program. So organizational metrics are required to be collected on a monthly basis and returned to the local governance group and the ECC, and these will include things like number of referrals received and accepted, number of referrals received not accepted, number of patients offered cardiac rehabilitation who attend the initial assessment, average wait time, which we know is very poor in Ireland, and we need to do a lot of work to improve that, and this model of care tries to move in the right direction in that regard. A number of patients who undergo initial assessment and an end of program assessment. So that's the start. The model of care also outlines the need to more standardize the reporting of information from cardiac rehabilitation services in Ireland. And we recommend that we move to measuring and monitoring and quality improvement at a local level, but also importantly at a national level. And part of this is to establish and implement and provide some resources for a national clinical audit on cardiac rehabilitation, which will be a first of its kind. And I think that's a step in the right direction. Again, we're on a journey, we're not at the finish line. And then key to patient-centered care is the patient voice. And the model of care recommends that the patient experience and outcome be measured as part of the monitoring and evaluation of the cardiac rehab services delivery under this new model of care. So if you read the document, you'll see that we have some focus on patient experience. And we hope to actually develop some standardized validated instruments for patient-reported outcomes, PROMs, so that we can capture information on things like health-related quality of life and impact of the service on patients. And so Susan is, we're very lucky in Galway and in Sale to have Susan, who's an international expert in cardiac rehab and really passionate about delivering cardiac rehab and improving outcomes for patients and the experience of the patient. And she's going to be leading a pilot, which we hope to then move nationally. So I'm very excited about that aspect of the model of care. And I suppose the thing to emphasize again is that we will be collecting data. So when we collect data, we'll know how we're doing, or at least we'll have a better understanding of how we're doing. We'll be able to say objectively if this model of care has made an impact, how it's made an impact, where we need to improve.
That's great, Bill. Thanks for that. And I suppose continuing the theme about quality of care, I suppose the staff experience and the staff voice is particularly important also in terms of listening to staff and their experience. And I wonder, Susan, what has been the experience in your area around delivering integrated cardiac rehabilitation to date?
Yeah, so we've been doing a lot of talking to the teams. It hasn't been all plain sailing. I think we have to recognise that there were existing hospital-based cardiac rehabilitation practitioners who've been there for many years, running programs on not great resources, and unlike other cardiology services, which have expanded over the years, like primary PCI and TAVI and electrophysiology, and it's only right they should have expanded, but we haven't seen the same expansion for hospital-based cardiac rehabilitation, and that's wrong. So I have staff locally who have no administrative support, so they're doing basic grade clerical duties. That's not right. And how can we ask them to collect data when they don't even have admin support? So I got a lot of feedback around these issues and resources going into the community, and why aren't they getting more resource? And I think we have to face this head on, and they're absolutely right. I've been adamant from the start that it's not one versus the other. Both are needed. Both are equally important. Both will help transform care, but both need to be equally supported. And we will be very loud about that, Sarah, with the HSE. We need the resources so both can do their job properly, and we can do it in an integrated fashion.
Thanks, Susan. I just see a couple of questions coming in here around heart failure and patients living with heart failure and accessing cardiac rehabilitation. Ken, you had mentioned in your piece there around difficulty in accessing for this cohort. Can you just tell us a little bit about that and how the model of care might support that?
Yeah, well, I suppose in the context of cardiac rehab in general, and for its more clearly or historically clearly indicated needs of CVD and post-cardiac intervention, in that area was never being properly resourced. Heart failure, certainly where the indication is equally clearly indicated at present, has been further, I suppose, disenfranchised up to now. And I think what we'll have to do is, with this resource, see what we can do to reverse that, because they're a population who will significantly benefit from a structured cardiac rehab program. There's no doubt about that now in the international literature. And I think it's been a resource restriction as much, and possibly also a sense that that the understanding of the benefit of rehabilitation in heart failure patients hasn't extended beyond the rehab professionals, where it is well understood. And that's probably an education process that we need to undertake within the cardiovascular community in general, but wider, to ensure that the heart failure population also see the benefit of this increased resource.
Great, Ken. So listen, we'll have to round it up there, just conscious of the time. I just want to say that you know, the themes that are strongly coming through for this model of care are around increasing patient choice, offering a patient-centered service, offering timely access as close to home as possible, and high quality care that's standardized across the country. These are the important themes, and the model of care really strongly pulls these themes forward, and this is what we will be looking to implement going forward as we take the model of care forward for implementation. I just want to say a very quick word of thanks to all our speakers today, and thank you to all our attendees for coming. We've had enormous interest, which really speaks to the importance of cardiac rehabilitation and the enthusiasm that's out there for this model of care, and to really enhance the services that are available to patients in this area. Thank you for all of your questions that have come in. We've touched on as many as we could today, but as I say, we will be developing a frequently asked questions document, which we will circulate to everybody that has registered for the webinar today, and that will support sites in their implementation journey. So just to say thank you very much, thanks to all of you again, and that's it.